Okay, guys, I'm going to talk a little bit on basics of EP study. Now, why do you do an EP study? Now, it is to examine specific parts of the heart's electrical system. So that is the idea behind the EP study. And you then get the intracardiac electrograms because you place catheters at different positions. So first of all, you need to know something about the electrical conduction system, which I believe all of you would know by this time. So you have in the electrical conduction system the sinoatrial node, you have intra-atrial tract, you have a compact AV node, you have a central fibrous body, and then you have the His bundle before it starts bifurcating into bundle branches, right and left bundle branch, and then into the Purkinje fibers. Now this is the conduction system of the heart, which shows you the sinoatrial node location just at the crista terminalis, just where the SVC joins the right atrium, which is the blue structure, and then you have the interatrial tracts, which then come and join the compact AV node. Then you have the His bundle here, which is in a long distance, and then it bifurcates into left and the right bundle. Now this is an important area if you're doing electrophysiology study, because one thing which you should not do is damage one's own electrical conduction system. So you need to be aware of this space, that is the triangle of Koch, that is formed by the base is formed by the tricuspid annulus, and then you have the coronary sinus ostium as the base of the triangle, and on the top you have the tendon of Todoros, and the apex is pointing towards the compact AV node. This is another diagrammatic representation. So you can see the compact AV node here along with the His bundle, and your slow pathway is just about a few millimeters away from it if you're doing an dual AV nodal ablation. So there is not a lot of distance. So what are the intracardiac recording sites? Now we would like to know what the right atrium, the high right atrium, is doing, because that's where the SA node is. We would like to have a recording in the His bundle, because that would tell you about the AV node. You would probably like to know about the right ventricular apex, because then you would know the conduction between the His bundle and the ventricle. And you would like a catheter or the conduction within the coronary sinus, because it goes into the posterior AV groove and it gives you the electrical conduction within the left ventricle. In certain occasions, you might need to have a catheter in the right ventricular outflow tract or in the left ventricle. So where do we keep our catheters? So one, we keep a high right atrium catheter here. Now this is a LAO projection here. You can see the coronary sinus catheter. You can see the His and the right ventricle. So you want one catheter in the high SA node. Some people put the coronary sinus catheter from above, and some people put it from the femoral vein. We do put it from the femoral vein down here in Narayana. One catheter in the right ventricular apex and one in the His. So you get 4 different recording sites, and this is an LAO projection which shows your right atrial catheter here. You can see the CS catheter, and then you can see the His and the right ventricle catheter. This is in real time. This is how you would see them. This is an LAO projection, and you can see the right ventricle catheter here down facing you, His, and the ablation catheter. I would come back to this later. Now, one of the important things if you're doing electrophysiology is you need to be good at fluoroscopy, or you need to know your structures, what it means in fluoroscopy, because most of your burning is not only based on your electrical recording, but also on the fluoroscopy. it is electroanatomical mapping. So you need to be good at your fluoroscopic images. So you need to know the structures in the anteroposterior view. How would your coronary sinus catheter look? Where would your high right atrial catheter be? Where would your right ventricular apex catheter be? And the his would be somewhere here. The CS will go somewhere here, and just above would be the his. It's different in the right anterior oblique view, because in this, the coronary sinus catheter would go down like this and point upwards, whereas your his catheter would come straight up like this blue thing here, and the right ventricle catheter goes down straight down here. It's different in left anterior oblique projection. You have on pass 2 valves. So your his catheter would be higher up here. So this is just below. So this is your tricuspid valve annulus, and just below higher up is your his. Your coronary sinus catheter goes because your ostium is in the posterior side here. It goes down like this and goes into the interatrial groove. Okay. And your right ventricular catheter, I showed you on the other occasion, it comes directly facing you down like here, and the high right atrial catheter will go up here. So that's the reason you need to be good with your fluoroscopic projections. And one of the best things to do is take a few coronary angiograms, because your circumflex, anterior descending, and the right coronary would give you some sort of information what it would mean. Now, LAO projection is very important for us, as I said to you. So 2 valves are on course. Your coronary sinus catheter goes down like this below. So then you have your coronary sinus, which is below between 3 and 6 o'clock, and higher up is the his. So again, you can see the tricuspid valve here and the mitral valve, and the coronary sinus catheter it is a decapolar catheter, and it has different recordings. So normally it is from 1 to 10. 1 is the distal most. 1, 2 is the distal most, that is in the left free wall. 3, 4 again is in the left free wall. 5, 6 comes nearly to the septal side. 7, 8 is almost towards the right ventricular side or the right atrial side, and 9, 10 is near the CSOs. So the coronary sinus activation will give you a good idea if there is any accessory pathways. Let's imagine the accessory pathway is in the left free wall. So then the earliest activation would be in CS34. So then we need some equipment for EP study. You need a patient, and then you need a sensing and pacing, which is the catheters. You need the control box. You need a recorder, a stimulator, and you need a display. And this is what it looks like. That's the reason most people don't like to do EP. You're sitting there alone, mapping for hours. So what is the sequence of activation when we put different catheters? So if you look at the baseline ECG here, so the activation usually starts in the SA node. So the HRA, the high right atrial catheter, should be the first one. Then it should come through the interatrial tract to the his. The next A should be in the his. The next one, because it also crosses and then goes to the interatrial groove. So then the next one should be in your CS, and then the right ventricle. So that is the sequence of activation. So that's the normal sequence of activation. So let us put each catheter. So first, high right atrial electrogram. So this is your surface ECG. So the high right atrial electrogram nearly corresponds to your P wave, the beginning of the P wave, because your SA node is very close by. Then you have your his. So there is some distance between the high right atrial and the his, because it has to go through the interatrial tracts. Okay. So in the his, you get an AH and a H wave. We'll come back to that later. Then you have the coronary sinus catheters. So it is from proximal, mid to distal coronary sinus. So the proximal one is 9 and 10, as I said to you before. The distal one is 1 and 2. So your activation sequence should be from high right atrium, his, then the proximal CS 9 and 10, followed by mid CS, followed by distal CS. So that's the normal activation. Then we also put a ventricular catheter, which gives us the V wave or the right ventricular activation. So once you have your baseline catheters, what you do is you measure the baseline intervals. One is the sinus cycle length. So what is the basic cycle length? That gives you a measurement of the heart rate of the patient as well. Around 600 milliseconds is roughly around 100 beats per minute. You can measure your QRS duration, you can measure your PR interval, and you can measure your QTC or QT interval. Now the PR interval and the QRS duration is extremely essential because if you do damage any of the structures, you would know. So you need to measure it at the baseline. And then we look at the intracardiac measurements. So we look at the AH interval, we look at the HV interval, we measure the sinus cycle length, which is again the same thing similar to RR interval. So first, let us look at the AH interval. So the AH interval is from the proximal A from the his bundle electrogram to the H wave. So that is conduction within the node because it is coming from the high right atrium and it is coming to the his. So this gives you conduction within the AV node and the his bundle there. Okay, the proximal his bundle. So the normal value is between 50 to 140 milliseconds. Okay. The next thing is which we measure is the HV. So this is the distal his conduction from his to the Purkinje fibers, your ventricular electrogram. So that gives you conduction between the his bundle and into the bundle branches and into the Purkinje fibers. So the earliest activation what you see. So the normal value here is 35 to 55 milliseconds. It's a quick activation once it goes to the his. Now why these baseline measurements are important, like sometimes you can have prolongation of AH. Like if you have a prolongation of PR interval, it is important to see whether the prolongation is in the AH or in the HV. Now prolongation in the AH itself, usually you can just manage, it's benign, you can manage the patient without doing anything to them. Whereas if the prolongation is in the HV, this itself, so these patients are at risk. So then you need to do the EP study to prove that whether they have any problems. Like here, you have a first degree AV block with left bundle branch block. Look at the HV interval, which is 165 milliseconds. I said to you the normal value is 55 milliseconds. This is markedly prolonged. So this patient would definitely benefit from some kind of a pacemaker. So once you have done that, we have different EP pacing protocols. So first, you have to put the catheters in. Once you put the catheters in, you attach the catheters to your recorder. Then you have the display. Then you look at your fluoroscopy to see where your catheters are. And once you have done all of that and you measured all your basic cycle lengths and basic measurements, then you get into the EP pacing protocol. So we measure in milliseconds in EP lab. So 600 milliseconds is the cycle length, or from AA 600 seconds, that's roughly 100 beats per minute. So the lesser the milliseconds, then your heart rate goes up. It is number of squares basically. 200 milliseconds is one big square on your ECG. So it has to be 300 beats per minute. Okay. Then we have our own EP talk, so that nobody can understand what we are talking. So we talk about stimulus, which is just a small electrical current. Then we say S1, S2, S3, S4. So the S1 is the first stimulus which we give, and we usually give S1 in a drivetrain. Again, you don't understand what a drivetrain is, so that's again an EP tox. Okay, and then we say S2. S2 is the first premature stimulus following S1, and then we might give extra stimulus S3 and S4. I think by this time most of you are confused, and that's the idea with EP. And then we have different other talks. We talk about train, that is single burst of phase stimuli. So I'll come to that because we talk about all of these things: incremental burst pacing, ramp pacing, burst pacing. So what do we do with the incremental or overdrive burst pacing? We give stimulus. The S1, this is continuous stimuli. So this is given like, I would start that at 500 milliseconds, then come to 480 milliseconds, 480 milliseconds, and then come down to 460 milliseconds, 460 milliseconds. This is to see the conduction, whether your antegrade or the retrograde conduction is good enough. So as I come down with my cycle length, if you're facing the atrium, then it should be able to conduct into the ventricle up to a certain cycle length. If it is not conductive, then there should be problem at some point. Like if I'm trying to pace the atria and I'm pacing it at 500 milliseconds, and I'm gradually coming down to 400 milliseconds. Now the AV node should be able to conduct these impulses. 400 milliseconds is 150 beats per minute, so the AV node should be able to conduct this. However, if we can see that the patient is having Wenckebach phenomenon at 400 or 420 milliseconds, then we automatically know that he should have some problem with the conduction tissue. Okay. Now with the extra stimulus, again we give a drivetrain at a specific length of 500 milliseconds or 600 milliseconds, and then we give some extra stimuli. Now this is slightly complex, but I'll try and explain to you on the next as we go along. Now why do we do a programmed stimulation? One is to induce a reentrant arrhythmia or rule out a reentrant arrhythmia, identify extra pathways, terminate arrhythmias, and also to see what the basic conduction is. How does it conduct from atrium to ventricle? How does it conduct from ventricle to atrium? Now this is what we do at our hospital. So you can see the coronary sinus catheters here, CS1, 2. So we all place it in a different way. So some people would have CS catheters here with his above this. Some people would have CS first. So every hospital would have its own protocol. So in our hospital, so this is normal conduction. So the earliest, I do not have a HRA. The MAP catheter here is in the right ventricle. So the earliest conduction here. Now this is the P wave. The next thing, earliest A, which you're seeing is in the proximal here. This is the A. So this is your P wave here. So I unfortunately can't draw a line here, but I've drawn a line here, the red line. The earliest A is in the his, then the his distal, then CS9 and 10. So that is the mouth of the coronary sinus. Then it is 7, 8. Then it is 5, 6. So on. So the CS1, 2 is the last one which is activated. So this is normal midline conduction. So we call this as normal midline conduction. And also what you can see is there is a gap between the A and the B, and the PR interval is normal. So there is no P excitation. So this is a normal conduction. So the next thing which we measure is the HV. And then we start our EP study. Normally, most of the centers start the EP study from right ventricular pacing. The reason behind this is, if you pace the right ventricle in a normal circumstance, the only way which it can go up is through the bundle AV node into the atrium. So that is a normal midline conduction. So when you place the right ventricle here, the only way it can go up is the his, proximal, and the distal series. So it is going through the normal AV node. Now let me go to the previous one. So here I am giving an extra stimulus. This is this drive tray which is at 600 milliseconds, and the next one is the extra stimulus which is at 400 milliseconds. Now I am giving an extra stimulus at 320 milliseconds. So when I give an extra stimulus at 320 milliseconds, there is a delay in the AV node. That is a property of the AV node. The earlier stimulus which it gets, it starts delaying a bit more. That is a protective mechanism. If we didn't have it, all the atrial flutter and fibrillation would be conducted 1:1. So there is a decremental conduction. So as I am giving more extra stimuli, it separates. So that is delayed in the AV node, but it is still a midline conduction. So it is a normal conduction. Okay. In fact, this is quite. And then finally, I give an extra stimulus which is 240 milliseconds here, which is not conducted because we have reached the refractory period of the AV node. So now it says I will not conduct it. So beyond this, there is no point in giving any more extra stimuli. I have reached the effective refractory period of the AV node. Okay, this is from VA. This is not a normal conduction for the AV node. So we also need to look at this from the AV side, from the A side. Okay. So this is what we call as retrograde curve because it is from the V. We also do similarly from the coronary sinus pacing, or we usually do it with 3 catheters. Hence we start pacing from. Hence we do the pacing from the coronary sinus. Whereas some people do have a catheter in the HRA as well. So then they pace from the high right atrium. So here I am pacing from CS56, and then I am looking for conduction. Okay. So normally when you pace from the CS catheter, so the CS catheter is adjacent to your his, so it should go to normal midline conduction. There should be a separation from a A to a B. Okay. Now this is what the normal antegrade curve should look like if you're doing HRA, his, proximal CS, mid CS, distal CS, and a B. As I said to you, people place catheters in different ways. So every unit will have their own way of placing the MAT electrograms. Now let us take how do we diagnose. This is just a simple example, just a basic, so that you can have some sort of an understanding of what we do in the lab. So let us take an example of AV and RT. So for atrioventricular nodal tachycardia, you need to have a dual AV nodes. They'll have to have a fast pathway and a slow pathway. So normally what happens? It comes down the fast pathway. By the time it tries to go up the slow pathway, you have impulses coming antegradely here. They collide and they subside. So it comes through the fast pathway and goes into the ventricle. Now during the EP study, if we start giving extra stimulus, this is where the extra stimulus is important. I'm giving the extra stimulus earlier and earlier and earlier. So then I reach the effective refractory period of the fast pathway. Then the only way it can now conduct is through the slow pathway. And it tries to come up but fails because the impulses collide. Impulse goes to the ventricle, but it can't go up and form a loop. But if you give a very timely extra stimulus, wherein the slow, it comes now down the slow pathway, because this is as the effective refractory period is reached, it can't come down here. But as it comes down here and tries to go up, the fast pathway has now recovered. Then it forms a loop. Understood? So if this had recovered here, then it would go up and it would form a loop. So then you start the AV nodal re-entry tachycardia. And that's the reason the ECG is also quite interesting, because it is coming down the slow pathway and it goes into the ventricle. immediately, by the time it is reaching the ventricle through the fast pathway, it is reaching the atria. So the P waves are hidden. So how do we do this in the lab? So here I am placing the CS56 as I showed you before, or you can place any of the CS electrodes. Ideally CS56 or 78 because it is nearby to your his. Okay, or you can place your high right atrium. Does not matter. So I am giving here an extra stimulus at 320 milliseconds. So you can see A, and this is a small h here. So this is the AH interval, which is 170 milliseconds. It is going through the fast path. It will start decrementing. You should not have it prolonged at the baseline. Okay. So then I give a still earlier extra stimulus. Okay. Now this is at 300. AH interval slightly prolongs to 188 milliseconds. Because I am giving an earlier extra stimulus, the AV node is delaying the conduction. I give still an earlier extra stimulus 280. Can you see this difference here? Here A to B, A to B. There is a sudden jump. Now what is happening is we have reached the effective refractory period here for the fast pathway, and the only way it can conduct is through the slow pathway. So sudden, because it is a slow pathway, the AH is prolonged. So here I know that there is an AH jump. So immediately I know that there is a dual AV node in this patient. Does it mean that it can develop a tachycardia? No, that has to be proven, because a lot of patients do have dual AV nodes but might not ever form a circuit. So for that to fulfill, we need to show at least 2 to 3 beats which form a circuit. Now if I reduce it further, okay, now here it is in 280 milliseconds itself. I tried again, so it went through the A, H, and here, okay, and then suddenly what you can see is you're developing a tachycardia. So you can see here V and A are all on the same line. V and A are all on the same line because it is conducting into the atria and ventricle simultaneously. And sometimes because of that you have a pseudo R in your V1. If you look at your baseline ECG to the, let us see if you can see one. See, this is flat here. Okay. Look, there is a notch now here. So pseudo R is quite a useful thing for AV and RT. And then you can look at your ECG, surface ECG at the same time when you're doing the EP study. So it gives you an indication it's a narrow complex tachycardia. Okay. So then what do we do? As I said to you, now I take an ablation catheter and I start mapping the region. So first I go to the his region. Now you can see A, H, and B. Do we burn here? No, because if we burn here, he will need a pacemaker. So that's the reason you need to have electroanatomical mapping. Okay, so we look at this, and we also look at the wherever catheters are. So now this is where his catheter is, which is directly at 12 o'clock position. I know my CS catheter is somewhere here. So the slow pathway is posterior. So I'm coming down to the CS region, going away from his bundle, and that's where my ablation distal would be. Okay, and I'm near the, when you come near the CS os, you're near the tricuspid valve annulus. So there, what you should get is you should get a small a and a large b, because I'm near the annulus. That is the AV ring. I do not have any his signal here. So I'm looking at the fluoroscopy. I'm looking at my signals. Only when you're confident and you have your good AHV here in your his catheter, then we start our ablation. And when we start our ablation, you get usually a typical slow junctional rhythm. So you can see the junctional rhythm here. So it's up straight on the straight line. Okay, it should be slow junctional rhythm. If you're burning the fast pathway, you will have an accelerated junctional rhythm, time to stop immediately, because your catheter might have moved. Okay. So you get a slow junctional rhythm, and then it starts getting sinus. That usually means that you've done good. Once you have done burned for 60 minutes or sometimes slightly longer, you retest. You give isoprene, you give atropine, and you start giving the extra stimulus now. And now when we give the extra stimulus, I'm giving 2 extra stimulus, 400, 280, 360, or how much is it now? Yeah, 300, and you can see it is blocked. It is not conducting anymore. The reason is, at this time, the fast pathway, even at that point, it blocked, but it conducted through the slow pathway. Now that there is no slow pathway, it blocks. So here you're guaranteed that you have done good, or you've done a slow pathway ablation. So typically the AVRT, you can look at your AVRT, whether it is an orthodromic or an antidromic AVRT, whether it is a manifest pre-excitation or a concealed. If it is manifest, you will have pre-excitation of the ECG. Okay. If you don't have manifest, then you need to rely on your pacing to see how the conduction is. Is it going midline or is it going through accessory pathways? So that's when the CS catheter is extremely helpful. Now, if this is a typical tachycardia here, which is a left lateral pathway, you can see the tachycardia B, and look where the earliest A is. It is in CS 1-2. CS 9-10 is the last. CS 1-2 is the earliest. So the only way it could have reached 1-2 earliest is through a left free wall pathway. So here very clear that is the left free wall pathway. This is another example. CS 1-2, you have fusion between B and A, because B and A is very close to each other. So you have fusion. Again another example. Now this is a different thing. This is a manifest free wall pathway. So when you have pre-excitation, you can see the pre-excitation here, delta wave. Now our paper speed is usually very high, so that's the reason you see very broad. Okay. Now when you see here, what happens is you have an A. A is coming through the right way, but look at the B. You have a nice AV separation, AV separation, AV separation. It is getting narrower, and it is almost fused in CS 1-2. That is because it is immediately going through the CS 1-2, and that is the reason for your delta wave. Now, if I put a line here, exactly where the B is, you can see that's where the delta wave starts. Because now it is going through the pathway. So if you have a manifest free wall pathway, it becomes easier for me to burn them, because I can see where exactly it is and burn in sinus rhythm. Whereas with the concealed pathway, if it is with the V pacing, then you have to pace them. Now here, this is something interesting. Now at initial drivetrain, it is going through the normal midline conduction. However, when I give the extra stimulus, which is 380 milliseconds, then what is happening is you have reached the refractory period of the node. So it can't go through the node anymore. Now it goes through the pathway, because it is not the accessory pathway has not reached the refractory period. So in EP study, that's the reason you need to keep your eyes wide open all the time. You never know when you will see what. Okay. I think this is just a taste of the EP or what we do in our lab. As you can see, it is not very scary. It is quite interesting. It is time consuming at times. You need to have interest. But as long as your first thing is, as in any case, that do not do any harm, know what you're doing, then it is a very interesting topic. So hope you have learned something, and hopefully when I show it next time, you would be able to tell me what pathways are. Okay. Bye everyone. Over transmission. That is long back, not now. Okay, well, goodbye. So there we stop. Okay. No. Leave conference.